Okay, so I'm Horst von Reken. Most of you probably know me, Biomedical Engineering. I'd like to welcome you all to today's speaker for the APP and FES Center. We're honored to have Mike Yaszemski from the Mayo Clinic. So I've known Mike for quite a while. I would almost say he was, I met him at a pivotal point in my career in 1993. I was in Houston. He was good friends with my master's advisor, Tony Mikos. And in fact, Mike and I wrote my first scientific publication together, so I have a warm place in my heart for Mike. He's definitely an incredibly accomplished clinician, scientist. He started as a chemical engineer, so we followed the same tracks. He was at Lehigh, I was at Rice. Then he got his MD at Georgetown. He got a PhD at MIT, and has, I'd say, an amazing list of scientific publications that any faculty member would be proud of. On top of that, he also has a clinical practice in spine surgery and oncology. And I think today he's going to talk about sort of how he marries some of those two aspects, and is a very impressive clinician scientist that he can juggle those two so well. And hope you all give a warm welcome to Dr. Yaszemski.
Horst, thanks very much for a very kind introduction. It's nice to see a number of my friends here, and hopefully meet some new folks and make some new friends. Give me a moment to put the mic on. And I hope that works well. What I'd like to talk about today is a couple things. I think we have an hour total, including questions. So I put a couple stop points in, and as it gets close, I'll just wrap up when we have to leave some time for questions. But as an outline, I'd like to start first with clinical needs for regeneration. And what I'll say there before we go through the rest of the outline is, here at our institution, we have this thing about translation being the bench to the bedside. I will submit to you that I think that's incorrect. I think that it's the bedside to the bench and back, and once you make that loop, you keep going around and making it better and better and better. But the clear description of an unmet clinical need, I think, starts it. And you take that to the lab and decide what tools you need to work with to address that problem, and you'll come up with something very focused and that addresses something that the clinicians can use caring for the patients. We'll move on to polymers, polymer design, synthesis, and characterization. As Horst mentioned, we're fellow chemical engineers, so we do polymer synthesis, polymer physical chemistry, polymer processing, scaffold fabrication, which will be the next bullet. We'll do some controlled delivery, and I'll try to say where I think that's useful. The two topics that I chose to highlight these processes are bone and nerve regeneration. And I'd like to talk about the Armed Forces Institute of Regenerative Medicine, which I think is an effort by our government and scientists and clinicians that really exemplifies starting with an unmet clinical need. And I'll give a few examples as we start. That's my disclosure. Got some grants. Started a company, actually. Tony Mikos and I, Horst mentioned Tony. Tony and I started this company in 1994. We spent a lot of other people's money, haven't made a penny yet, but hopefully we'll come up with some good things for patients in the long run. I'm from Mayo Clinic. A little history about Mayo. I talked about the Armed Forces Institute of Regenerative Medicine. We have a long military history at Mayo. The guy in the middle is the father. The two guys on the outside are his brothers, Charles and William Mayo. The clinic is mostly known for them, the two brothers, as starting it. But their dad was a country doc, and he was in the Union Army in the Civil War. And in 1863 got sent to Minnesota and spent the last 2 years as a Union Army surgeon in Minnesota. And the war ended in 1865. He stayed in the Army until 1867. And I don't know if any of you are from military families or in the military, but it's when I talk about Mayo Clinic to my military colleagues, they know this situation very well. It hasn't changed in over 150 years. When he got out of the Army, they had 6 kids, and Mrs. Mayo said, "I've been trailing you around with these kids for a long time. We're finally at a point where you're no longer in the Army, they're not moving you, and we don't have to move. We got a house, the kids are in school, we're staying right here." And so why we're in that desolate, frozen tundra of Minnesota is actually a consequence of him being in the military. Now, clinical needs. I'll just show, I hope everybody's okay with looking at clinical things. If you're not, there's 4 or 5 slides. Just close your eyes or look the other way. This is a guy I took care of in Iraq. And you can see he's got a hand that looks pretty good. It's perfused pretty well. But you know, he doesn't need either just bone regeneration or nerve regeneration or skin regeneration or tendon. He needs all of them. And so composite tissues is an important thing. And as many of us start working in specific parts of regenerative medicine / tissue engineering, we need to remember that the patients need more than the thing that we're working on. They need more than just a bone or a nerve or a tendon or skin or cartilage. They need composite tissue, and we should be thinking about that as we work in our specific areas. Balad, Iraq, was our theater hospital. This is a fellow with compartment syndrome. He gets his leg open to relieve the pressure so the muscles and the nerves don't die. But this creates a problem. That wound's going to gap open, and things inside may stay alive, things inside may die. But if they do, he'll need whatever they are, muscles and tendons and nerve and bone. He'll need skin to cover the hole. Here's another guy who has a big, after I did this guy, the fellow who's got his hand on the right putting the sucker through that little hole, the sucker tip you see comes in. That was an AK-47 round, makes a little entrance wound, and just blows things apart inside. And again, the common theme with all of these things is there's many types of tissue missing. As we get into tissue regeneration planning, we should recognize that there are many types. And then I'll just give an example from my practice of non-trauma. It's not only in trauma that we need these different types of tissues. This is a care for tumors of the spine and pelvis and sacrum. If we have a malignant tumor there that we have to take out, and we leave what's left on the right side there are also multiple types of tissues missing. This is an example of a woman who had a cancer called a chordoma. This is the piece of her that we took out. We used her own tissues because we can get composite tissues, but we got to borrow from Peter to pay Paul. These are the fibulae. Our plastic surgeons take them off with blood vessels. We put them in together like that, but look at the hole. I mean, you know, this is the best we can do right now. We put those structural tissues in. We put bone graft around to fill up the rest of the gap. But what's missing in there, the articulations are gone. The nerves are gone. This person's not going to have bowel, bladder, or sexual function left. Really, the ability to move around is decreased because this is not as good as having put back in what we took out. Skin. Here's a guy that was burned. In burns, a lot of times the skin is gone. We have to release it because it becomes non-compliant and will inhibit respiration. It'll cause those compartment syndromes that I showed earlier. And the needs again, starting with the unmet needs, first thing is keep the person alive. They got to breathe to stay alive. We've got to cut this charred skin so their chest can move in and out. We got to close it so they don't get infected. Donor skin, most of them may be burned. This may be a person 80–90% of their skin surface area burned. We just don't have skin to borrow. And I'll show a little work at the end from a firm from our colleague Steve Boyce in Cincinnati who's trying to address this. Scarring and burns, et cetera, they're down at the bottom of the list, but I'll tell you, people worry about them, especially if they're on parts that you can see. If they're on their hands or their face that others are going to look at. People, after they survive and get whatever function they're going to get, they care what they look like. Okay, so let's talk a little about the strategy. Scaffold, we can talk perhaps if people have alternate definitions for scaffold. I view scaffold as a synthetic analog of the extracellular matrix, something that provides structure to the tissue that we want to regrow, something that the cells that make the natural extracellular matrix will like, meaning they'll attach to it, they'll proliferate, they'll synthesize their matrix. We need those cells. Either we got to put them in or they got to come from somewhere else in the body. They need to be attractive. And the bioactive molecules that will either attract them or help them to do the job that they need to do. Now, scaffolds can be anything. These analogs of the matrix, we can make them out of metals, ceramics, natural tissue, polymers, synthetic tissue, and just a couple examples of each there. But of course, people do what they think they know how to do. Being a chemical engineer, polymer chemistry is something I did. I had an opportunity before going to medical school to work as a synthetic polymer chemist in industry. I worked for GAF Corporation for a while. So we use polymers. And the thing that we try to exploit from the polymers is that we can control lots of things. So we can start with that unmet clinical need, say what we need to address it, and assess whether we can find a solution that includes polymers. Now, having said that, if that solution is amenable to use of a natural polymer, we use it. If a natural polymer is not amenable and we need to use a synthetic polymer, if there's something already in use by somebody somewhere, is FDA approved, and we can adapt it for our use, we use that. We only go to synthesis of novel polymers if the first two things don't pan out for whatever reason. But scaffolds for bone, let's talk about bone for a little bit. From a clinical perspective, we need either a structural bone or a bone void filler. This is the separation that we make into preformed scaffolds or injectable scaffolds. Preformed scaffolds, that's something that we would use for a missing piece of bone. Like that lady I showed you had no connection between her spine and her pelvis. If there's a gap that we need to fill, and we perhaps can use a preformed scaffold, something that matches the size and shape of what's missing and will turn into bone and hopefully go away after a while. Injectable scaffolds will be, there's a lot of push in all kinds of surgery these days for minimally invasive techniques. And I'll give an example of bone cysts. Simple bone cysts, little kids get them primarily in their proximal femur or their humerus. If we do something surgically, we got to make an approach. We've got to make a hole, move muscles aside, and get at it. Now, some of the cysts we can treat by injection, so we just put a needle in and we put some kind of scarring molecule in, like methylprednisolone, hope it scars down and heals with bone. But if we wanted to put a scaffold in, to get it in minimally invasively, we'd need to make it injectable. We'd put that same needle like we would to inject methylprednisolone. So we'd have to have a material that would flow, its rheology properties would be such that we could get it through a needle and it would fill up the hole. It would take the shape of the hole and then do the job of being analog extracellular matrix and turn into bone and go away. So I've got to show you some pictures where I'm from. This is our clinical practice building, our research, one of our research buildings, and our education buildings. And you see we show these nice pictures to people with sun and pretty flowers and things, but you live in Cleveland, so you know it too, but this is what it usually looks like in the winter. Just to be transparent and honest about where we all come from. Now let me show you a couple of the polymers we've used. This is a polymer that Tony Mikos and I have worked with a long time. This is something I synthesized for my PhD thesis, and we're still using it 25 years later. We chose it, and I give this as an example to say, how do we choose when we have to go to synthesizing the polymer? What choices do we make? We chose these two things, propylene glycol and fumaric acid, because if they degrade into that, we've got to have something that the body can take care of. So fumaric acid's an intermediary in the Krebs cycle. I'm assuming the body can take care of that. And propylene glycol has been used as a plasma expander as far back. The earliest I found was World War II. It's been used a long time. And for those of you that are on the clinical side of things, look at some of the IV bags that have different things in them that your patients get. Most of them will have propylene glycol as one of the constituents. And so we thought that since we can make an ester out of this, and esters can hydrolyze in the body and go away, that if we could make this work, this might be a good polymer to use. And we've used this for our bone program. It has, when we fabricate it via cross-linking through that fumaric acid double bond, it gets pretty strong. And I'll show in a moment why we've made some changes to that over the years. This was done, and I'll try to relate who did all the work, and forgive me if I miss a couple of them. This was done by Ismail Jabbar. He's a chemical engineering professor now at the University of South Carolina, when he was a fellow with me about 10 or 15 years ago. I asked Ismail if we could make this scaffold and put something that bone cells usually attach to, like hydroxyapatite, on the presenting surface. It would be a good thing. And I asked him to make a linker so we could get this thing a little bit away from the surface if the protein layer got adsorbed to the polymer when it was put in. We could maybe have some of these presenting groups out a distance, and I asked him to put different length linkers on and get HA at the end of it. And he came up with this that we've used intermittently over the year. We've come up with different ways of putting calcium phosphate on our scaffold internal surfaces, but these are the machinations we've gone through over the years to try to get that. Now, polycaprolactone fumarate, where this came from, for the PPF will not cross-link. When we make the pre-polymer change, they won't cross-link by themselves. The double bonds really can't get close enough to each other. It's a fairly rigid molecule with the propylene glycol just having 3 carbon units in it. We thought that maybe if we could make it a little longer, maybe those double bonds could position themselves in space where we could cross-link them without a small molecule. Now, we've used a variety of small molecules for PPF over the years, but that's something we have to account for. If we ever get to the FDA with it, we're going to have to tell them about that small molecule. They're going to have to be okay with that degradation product. We thought it would be good if we could just get rid of that. And we chose caprolactone. Caproic acid is just hexanoic acid. It's got 6 carbons. We thought if we had a couple more carbons, maybe the chains would move around and cross-link without a small molecule, and they do. And they do. And it's got some other neat properties that I'll go over. We use it for our nerve guidance channels now, and I'll go into why in a bit. Then we thought, well, can we put these together in different ways? And this will be the work of Shanfeng Wang. He's a professor in the material science department at the University of Tennessee now. I asked him to look at these 2 things we use and try to mix and match them and see if we could get some different properties out of them. So he made PPF co-PCl, and then he looked at differences in the polycaprolactone fraction. Now, I should go back a second and say, why do we choose caprolactone? We talked about, natural things first, things that are in use second, things that we synthesize third. But even when we synthesize something, if we can go back and use something in that synthesis that's already FDA approved, we try it. And we use polycaprolactone sutures all the time. So it's a standard suture that we use in surgery, degrades well, doesn't seem to cause any trouble in the body. So we figured, well, if we can make this part of the polymer and it degrades like polycaprolactone does, maybe that would be okay. But Shanfeng looked at the percent PCl fraction and tried to look at the different properties. And this sort of eye chart, I don't expect you to read it, but I just wanted to show a few of the synthesis pathways that we go. We make the PCl from a ring opening reaction with caprolactone, and the little line drawings show the different ways Shanfeng had put them together. He made a PCl co-PPF with an alternating short chain of caprolactone and polypropylene fumarate. Then he made tri-block copolymer so that the repeat was a tri-block, and he made a couple other types in between, and then looked at the properties. And so with the PCl fraction increasing, we can change the gelation point. Now, why is that important? I mentioned, let's start with a clinical need. The polymer that orthopedists are most used to working with is polymethyl methacrylate. We're creatures of habit. You get something with a powder in it, you get something in a brown vial with fluid in it, you break the vial, you mix the 2, you put them together. If you don't wait long enough, it's gooey and it runs, and you can't control where it goes. So you got to keep mixing until it gets a certain consistency. Then you can put it in a gun, a caulking gun, and push it somewhere if you want. But you got to time that because it's continuing to get hard. So between mixing and about 2 minutes, it doesn't have a good enough consistency to use. From about 2 minutes to maybe 6-7 minutes, you can inject it. After 7 minutes, it won't go through the gun anymore, but it's still then like silly putty. You can still mold it, and you can put it in somewhere. And after about 12-13 minutes, it's a rock, and what you got, you got. So rather than try to teach surgeons new things, we thought, well, let's work on the rheometry of these polymers we're using. And Shanfeng found, as you see, pure polypropylene fumarate's the yellow, and 80% caprolactones, that line down at the bottom, that pink line. And you can change the gelation time, the time which it becomes cross-linked enough that the molecular weight's infinite and it's just a solid cross-linked mass. You can change that over a wide range by changing the composition. And so change of composition is something that we use, and I'll go into when I look at the nerve tubes. When the properties aren't good, we can go back and work on composition as one of the things we change to get the properties we want. Cross-linking temperature is another. Again, the change of the PCl fraction from the yellow at the top down to the pink at the bottom changes the maximum temperature, and all of these temperatures are okay. Typically, we think of things that if it's less than 50 degrees C, you can touch most things in the body with it. When we work with PMMA, for example, if we're doing a metastatic spine tumor, usually for metastases, if the person's old and isn't going to live a long time. We try to cut down on the surgical time by filling the gap with a PMMA, i.e. a non-biologic reconstruction, and hope that it lasts the patient's lifetime. But PMMA can reach 110C. If any of you are residents or orthopedists in here, one of the things I do with the residents is when we put PMMA in somebody, I ask them to take the rest and hold it in their hand. And haven't found a person yet that can hold that. They have to put it down. It'll burn you. And I say, you know, the patient's anesthetized. They can't put it down, but that heat is touching their joint, their cartilage, their spinal cord, their nerves. And, you know, we go through this long dance, if you will, of putting cold water on it while it's polymerized and trying to put a barrier between it and something that might hurt. So in the synthesis of the polymers, keeping the temperature down is a goal. We like to see if we can get the job done without having it get too hot. The properties can change. We can control the thermal and morphology properties, et cetera. As you see on the right, it's since these polymers, the things that we measure mechanical properties in our biomechanics lab, for which you can ignore the viscous component, you know, we'll get a Young's modulus, et cetera. But for the polymers, we have to include the viscous component and measure the storage and loss moduli in a dynamic mechanical analysis rather than just, if you will, an Instron machine. And also the Williams-Landau-Ferry equation for viscosity's temperature dependence, are followed very nicely by this series of polymers that Sean Feng made. Now, let's look at a different one. We thought, okay, we made polycaprolactone fumarate. What else can we use? PEG is something that we use a lot, and we wanted to see if we could put PEG together with fumaric acid with the idea of making something injectable, because PEG's very hydrophilic, and we wanted to see if hydrogels would be useful. So this is something that Sean Joe made when he was working in Tony Mikos' lab, and we worked together on trying to make an injectable hydrogel. We've since modified this PEG fumarate in a lot of ways. We currently use it as in both our bone and nerve programs. This is Maruk Dadzatan's work. She's a polymer chemist, came to work with us. Actually, she was from here. Some of you may remember her here. She worked with Jim Anderson for 3 years. She's been with us about 4 or 5 years now. So she got very good training in Cleveland. So thank you all for getting her to us. But we thought, with respect to trying to get cartilage to regenerate, cartilage is aneural, avascular, and alymphatic, and the cartilage cells live by diffusion. We thought that if we made a hydrogel, maybe the cells could stay alive a longer time. And I asked Maruk to try to make this hydrogel. She made it with a short PEG change, and we call it now oligopolyethylene glycol fumarate, OPF. And the live dead assay at the right, they live pretty well. The cells live pretty well by diffusion because the hydrogel is well over 90% water, and wastes can get out and nutrients can get in pretty easily. And we can control the equilibrium swelling. So it's just, if you will, it's a spider web of polymer chains, and when they draw water in, they expand and expand and expand until the chains won't expand anymore. And we can control that amount of swelling, again, by the composition. There are other things, of course, we can do. The synthesis methods may be important. The molecular weight of the components may be important. Composition's an easy thing for us to change and try to get different properties. Now, why is the swelling important? You may have followed, there's a few things in the literature now. For us as orthopedists, bone morphogenic protein's a big deal. It's incredibly expensive, and we use it very infrequently. At least I use it very infrequently because of the cost. But sometimes when you're having a difficult problem, adding a little push from the BMP helps. It comes in collagen. So collagen acts in the formulation that they sell it. It acts a bit like a hydrogel in that it swells. There have been some problems with the swelling. There have been some musculovisceral column, esophagus, and trachea pressure from these, and so you got to be, when you're going to put something in that's hot, you got to be careful with it. When you put something in that's going to be swelling, you got to be careful with it. So now, once we make polymers, let's just talk about scaffold. So polymer processing is a whole other thing from polymer synthesis. We've got to make a useful thing. We've got to make something out of this polymer. So how do we do that? Now, David and I have worked together on this with one of the methods of solid freeform fabrication called laser stereolithography. And I'll give 2 examples of how we use those solid freeform fabrication technologies to make the things that we eventually want to put into people. This is the work of Kiwan Lee. Kiwan was one of my graduate students a couple of years ago, and he did a PhD thesis that incorporated SFF. So we can use Engineer, AutoCAD Pro Engineer. We have Pro Engineer is what we use. We make an STL file out of it, stereolithography.stl file, and we feed it to the machine, and the machine makes a piece. So Kiwan just showed that if we made a scaffold, if you will, that had rectangular geometry, external and internal, he could close off pores, he could change the size of pores, he could change the width of the struts. And when we make it in stereolithography, we make a support, it gets sliced, we photo cross-link it, and then post-processing we have to cut off the little pieces that were the support. Here's the machine. It's like we're far enough north that you have skating rinks here. It's like a Zamboni machine that does the ice. The Zamboni puts some water on the ice, gets a nice smooth surface, it freezes. This has the monomer. What we did, David, from when you had the machine, it takes our chemical technician a week to make 4 kilograms of polymer to fill in that big vat, because this was an industrial machine. So we made a small vat on the top that takes about 500 milligrams of polymer, and we can make smaller batches now. Our engineering department did a nice job, but the Pro Engineer tells the laser where to touch the surface. To make a scaffold by laser stereolithography, we have to have a polymer that can be cross-linked using photo initiation rather than redox initiation. The laser touches a spot, it gets solid, the rest of it stays liquid. The elevator moves like the Zamboni, more liquid monomer covers the top, the laser touches the correct spots on the next, and as it moves, it builds a piece. Now, how about another way? What do we use? This is our piezo inkjet printer, and this works by making a solid, but out of 2 things. So rather than laser photo initiation, this uses polystyrene and it uses wax. It uses a medium length wax that melts at about 65 degrees centigrade. And so when we put the STL file in this machine, rather than either remain liquid or solid at each level, you get either the wax or the polystyrene at each level, and the company puts colorants in them so we can see the difference in color. Now this was made, how we figured out how to use this was again made by Ismail Jabari while he was with us. Ismail found out that acetone was a solvent for the polystyrene and a non-solvent for the wax. And so if you follow the cartoons from the upper left, the machine makes something that's polystyrene and wax, and we plan it so that where we want the pores to be are the wax. So then we put this thing in acetone, the polystyrene goes away. It leaves a porous thing that's wax, and so now this becomes a wax loss process. We then take that porous thing that's wax and we flow the monomer in it, but this time instead of using photo initiation, we use redox initiation, and we put both an initiator and an accelerator in with the flowing monomer. It hardens within the pores, and once these polymers harden and cross-link, most of them don't melt until well over 150, 200 C. And so we simply then take that thing and raise the temperature a little above 65. The wax goes out. And we use this when we use a new material, because then we have a porous scaffold of any material that we can polymerize via a redox initiation. So those are the 2 we use. We have also fused deposition modeling and electrospinning that we use in the lab, but these are our 2 workhorses, these 2 to make scaffolds. Now Kiwan, I asked Kiwan to show me how good can the stereolithography machine be if we put an STL file in. And David, you and I were talking about the resolution earlier, but from about half of a millimeter to about a millimeter, it's pretty good, I would think. It's pretty good at making the internal architecture that we wanted to have. And Kiwan simply made these squares and round things. He tried to experiment a little bit. Now, how about interconnectivity? One of the issues when we make these scaffolds is we want tissue to grow into the pore spaces, and are they interconnected? I would submit to you that those scaffolds that Kiwan just made, that I showed on the last slide, they're interconnected. But we use a couple of other ways of making porosity. We use porogen leaching, we use gas foaming, and we've tried all of these over the years. Each of them has pluses and minuses. The porogen leaching, sometimes there's a bunch of big holes where the salt particles that we use for the porogen bunched up. Sometimes there's holes that aren't connected to anything else if the salt particle was by itself. Same problem with gas foaming. We put something in that during the reaction will make some CO2, and sometimes we got big bubbles, sometimes we got little bubbles. But there are a couple things that are in use. We talked earlier about scaffolds can be metals, can be ceramics. This is one that our hip and knee surgeons use a lot, this porous tantalum. So this is a regular three-dimensional dodecahedral structure that they make with polyurethane, and then they use chemical vapor deposition of tantalum over it. For whatever reason, bone loves this. This has become the preferred means for our hip surgeons of reconstructing large acetabular defects. The metal stays in, they put it together, it provides immediate support so you can get the patient up walking. The bone grows through this stuff in great fashion. So I wanted to put a couple of these in to show. We work with polymers, that's our bias. But there's lots of other ways to get the job done that you want to do. And our hip and knee surgeons are very happy with this porous tantalum. There's also another one on the market that's a porous titanium alloy. Two different companies make them, and I'm not sure which one, if either of them, they prefer. But if you see if the salt leaching and gas foaming, we go from this very regular dodecahedral structure in the porous tantalum to very irregular. And I will submit to you that when any of us show our salt leaching and gas foaming slides, we're showing you the best. You're seeing the best that it's going to be. We pick one that looks nice, but it's just not uniform enough and it's not predictable enough from my perspective. Now we are working, I've got one of our polymer chemists, Brett Runge. I've asked him to work on phase separation as a way to try to make an injectable scaffold. So one of the unmet needs, I think we've got the preformed scaffolds down pretty well with the solid freeform fabrication from the stereolithography machine. So we can make a piece pretty well now that's got a defined external geometry and a defined internal microarchitecture if we're going to fill a gap with an open surgical approach. But I would submit that neither we nor any of our colleagues has yet made an acceptable injectable scaffold that produces a regular interconnected porosity. I think that's still a problem, and we're trying to work now to see if we can get a pressure temperature composition combination that will allow that. So, you know, what would be the temperature range? From either room temperature or cool if we have to keep it, if we need it to stay as a single phase. To inject it, it has to be a single phase, something that fluid with good rheologic properties that we can inject. And so that has to be from either at or below room temperature. Maybe we can keep things cool. We bring them into the operating room, get it to room temperature, it'll inject. But somewhere between room temperature and body temperature, it's got to phase separate. And the phase separations can make microdomains that are very regular, and we're hoping that maybe we can make an injectable scaffold that will have regular connected porosity by that technique. So that's an open question. If anybody wants to work on that, we're looking for people who want to do that. I asked Keywan to say, well, suppose we wanted to close off some pores, and I just put these in because whatever he programmed from the stereolithography instrument happened when we made it. He can close pores randomly, et cetera, et cetera. Now, bimodal porosity. This was the work of Lee Chun Liu and Dieter Kempen. And I asked them the following. I said, okay, we got these large pores that we want tissue to grow into. Suppose we want to do controlled delivery into those pores. Suppose, for example, with this very expensive BMP, that we don't want half of it to go away, you know, with the surgical drain that we put in somebody. Can we embed the thing we want to deliver, the molecule we want to deliver, perhaps in microparticles, and embed that in the wall of the scaffold? And they were actually able to do this. They put microparticles that contained I think we used a Fitzy dextran as our model. They were able to get them into the pores, and I'll show something about the controlled release from those in a bit. So Dieter Kempen, again, his work, put the molecule of interest, I think, and again, Fitzy dextran is, I think, what he used, into microparticles, and then immobilize those, that sort of lunar landscape that you see in the lower right. That's the wall of a pore in the scaffold, and the bumps in it are the microparticles. So the diffusion path for the molecule is first to diffuse down a concentration gradient out of the microparticle and into the scaffold wall, and then to diffuse through the scaffold wall and into the pore. And thus, by choice of the nature of the microparticle, its composition, its molecular weight, its size, And the same thing for the wall. We can make a diffusion path that can have whatever we put in come out at a certain time and then hopefully act on whatever is in the pores of the scaffold. So here's just to try that. I asked Diederik and Li Chun to make a couple different diffusion pads because, again, from a clinical need, one of what we perceive as a problem with the BMP specifically is it's so expensive, and there's a burst release, and we take this incredibly expensive molecule and throw half of it away in the first day or two as it leaches out. And I would also submit that when I close a wound, the first thing in the space where I want bone to form is a hematoma. And there's no cells there for that BMP to act on. I know that there will be clinical colleagues who disagree with me on that, but I would challenge them to tell me after I close a surgical wound and put a drain in, that space has anything other than hematoma in it. But as you can see here, they showed us the BMP itself in gelatin, which is how it's supplied by the company that sells it now, comes out right away. And both the pink and the blue lines where we put polypropylene fumarate and or polypropylene fumarate and gelatin in the path blunts it a little bit. And we lose less of it initially and keep more of it around, maybe when cells are there for it to act on. Diederik also found us a way to save animals. He found that we could tag this BMP with I-125 and then just anesthetize the rats and do scintillation counting rather than have a group of 8 or 9 rats that we kill at each time point. That seemed to work out well. And in vivo, you see the same things. There's a big burst release when it's in gelatin alone. And as we put different layers in the diffusion path, it blunts the burst release a little bit and keeps the molecule around and coming out into the space where we want tissue a little bit later. We look at micro-CT. We also have a quantitative histomorphometry lab as part of our lab, and we provide these services to other labs at Mayo and to outside folks, both academic and industry. So we've started to look at, in addition to the histo, we've got a micro-CT scanner, and we look at these via micro-CT. This was from a segmental defect in a rat, segmental femur defect. And again, the microparticles through 1 and through 2, the PPF and the PPF gelatin, there was a little more bone, I think. It's certainly not a quantitative thing, but there was a little more bone in those two panels to the right than there was in the left, both at 6 weeks and 12 weeks. So this just shows quantitatively what we did from those pictures. And we made the most bone when we had the diffusion path to make the molecules come out later. So the questions that I still have, I'll just put these up because I don't know the answer, and Arnie, maybe you can tell me, because I suspect you do. But where do the osteoblast precursors come from in orthotopic and heterotopic bone regeneration, and might they arrive by the vascular system? And the thing that made me start wondering about the vascular system was there's a paper by one of our colleagues at Mayo, Sandeep Khosla, to where he got some GFP cells, put them in a rat's bone marrow in the pelvis, and then fractured the rat's clavicle, and then when the fracture healed, looked to see what kind of cells were there. There were a lot of GFP cells there. I suspect they came through the vascular system. So how in response to injury, the body knows to mobilize these cells, get them from the marrow to the site that they're needed. I'm not sure, but what it made me wonder from a tissue engineering perspective is, if that's true, can we exploit that a little bit? And saying what are the temporal and spatial relationships between vascularization of a space that we want to have bone and the osteoblast's presence there? Maybe we should get vessels there first and see what happens. So the next studies, again, were by Li Chun Liu. Li Chun won the AAOS Kappa Delta Award for this work. So what we did was take empty scaffolds with VEGF, scaffolds with BMP, and scaffolds with VEGF and BMP, and looked at, this is a rat femoral defect, and asked, what kind of vessels grow in. So the empty scaffold was our baseline, and you see up at the top the pictures where we got to, in our histo lab, we were able to put some contrast in the vessels and make a picture of them. But when we put the VEGF in, more vessels happened. When we put just BMP in, it was kind of sort of the same as empty. I guess I wouldn't expect BMP to make vessels, but we wanted to show that, if you will, as a control. And when we put them both together, about the same happened as when we had the VEGF alone. So we thought that more vessels happened with VEGF. But then when we looked at bone formation, empty scaffold, nothing. Just VEGF, nothing. Just BMP made a certain amount of bone. But, you know, although really the error bars overlapped, there was a little bit. There was a trend toward more when we released the VEGF first and the BMP second. And we did this experiment, as I showed from the release studies with the microparticles. So the VEGF came out earlier and the BMP came out later. Now, what does early and late mean? I don't know. That would take optimization experiments. But just as a kind of a proof of principle, could we get a little more bone to form if we proceeded the dosing of BMP with the dosing of VEGF? It seems to at least be a trend in that direction. Now, you know, where else will we go? I put a couple slides in here to sort of introduce a firm. I want to just watch till I don't go over them, but we're getting near the end, aren't we? This is a goat mandible. We put, again, metal in just because we were trying to work out the surgical procedure. Here's what a segmental defect looks like. We're going to redo these now with two of the posterior molars. Our craniomaxillofacial surgeon said that in people, when he gets defects here, and it includes teeth, it makes a connection between the oral cavity and the wound, and he has a flap that he knows how to do in people, but he wants to see if he can do that same flap in goats. So we've got this healed. The goat lives, it eats, it drinks and takes care of itself, so we're sure we could do this as a model. This is simply a model development, and we want to see if we can make that model development to include the part of the mandible that has teeth, which is what we're going to do next. We characterize these things, we embed them in methacrylate, we cut them on the Exact saw, and the Exact allows us to process specimens that have things in them that can include metal and soft tissue, and it will allow us to keep all of those in the same slide. So this is part of a firm. Although I don't do craniomaxillofacial work, it seems that there's a need for treatment of segmental defects in the mandible, and we're working toward making a model for that too. And the bone does grow through this metal. As I mentioned, our hip surgeons love it. And now this switches from scaffolds and polymers to just looking at some bone and some nerve. So, excuse me, from bone to nerve. So the challenges in nerve are crossing gaps. I think that the limiting factor is that nerves grow 1 millimeter a day. If you've got a nerve injury that's proximal, either up near the beginning of the sciatic nerve for the lower extremity or in the brachial plexus for the upper extremity, by the time you get to the most distal innervated muscle at 1 millimeter a day, even if everything works and it grows, you may find a non-receptive neuromuscular junction and an atrophic muscle. So I think that of the things we do, this one's going to need some basic science. Someone's going to need to figure out how to cross that millimeter a day nerve growth rate. Now, some mammals know how to do it. Whales, their nerves grow 8 centimeters a day. They go from a pretty big baby to an enormous adult, and the nerves keep up. So there's something about, I would guess, maybe the tension on the nerves, much like we in orthopedics do, this Lizarov technique of bone transport. If we pull it just the right amount, bone will fill in the gap as we move the external fixator. Maybe it's the same for nerves. I'll say that from the congressionally directed medical research programs, peer-reviewed orthopedic research program, we just made our decisions for the RFAs that'll come out in a couple of weeks, and we are including strategies to assess the rate of growth of peripheral nerves. So if any of you are working on that, please look for that, and please help solve this problem. And of course the accuracy. When you just connect two nerves, maybe what's on the top doesn't stay on the top. The nerves may mix, and then people have to relearn. Rob Spinner is our nerve surgeon at Mayo, and sural nerve is the best we can do now. So when we work on our animal models for nerve, we compare what we do to sural nerves. There's lots on the market. There's nothing new about this. About the best people can do with what's on the market is about a 2 centimeter gap. If there's a gap and the surgeon can mobilize it and get the ends for a primary repair, he or she does that. Much over 2 centimeters, they don't really work. We use compound muscle action potentials. We look at muscle volume mass. We look at histology. But what are the factors that we're going to think about in our lab to try to address? We're going to try to address the architecture, the surfaces, and the mechanical properties. Again, we use different things. We've used this polyethylene glycol fumarate as a hydrogel to put in these tubes to put cells in, to put molecules in. It goes away. This is another processing technique. Vacuum molding is how we make the nerve tubes, either single channel on the top or multi-channel on the bottom, with a porosity, as you see in the walls outside the channels, through which we can deliver things. Those things change by their diffusion rate changes by the radius, makes sense, and we can control that change via the composition and molecular weight of the polymers. Shape. Is shape important? Again, we try to use FDA-approved things, so we tried to make this out of PLGA, but it doesn't keep its shape, and I would submit that since the channels don't stay circular, axons trying to grow through them are going to have a hard time. So we went, this is where we use the PCLF that I thought, maybe we could use the PCLF for this. It keeps its shape, so we started working on that for our nerve tube, and we found a couple other things. If we etch the surface, as you can see, the two nerve lines we use, the PC12 and the SPL201, they, as we expose the scaffold to increases in both the concentration and the length of contact of alcohol, we get more and more roughness. The cells seem to like roughness, and more of them attach when it's rough. The chemical composition, so this again getting back to clinical needs. We made these nerve tubes, and Huang is our surgeon. She's an MD, PhD, microvascular surgeon from China. She's a full professor at Fudan University in Shanghai. Been working with us for about 5 years now. Her professor, Yudong Gu, has allowed her to come here. We've got it worked out with immigration that she comes for 3 months, goes back and takes care of her patients for 3 months. So we've got the privilege of having a full professor hand surgeon doing our rats. It's been a blessing. But she told me this stuff is no good. It doesn't hold the 10-0 suture, it pulls out. And so we went back to the chemist in the lab and said, look, change the composition a little bit, change the molecular weight, let's see what you can do. And so the pullout for the suture in the normal nerve, the perineural suture, is about there. This was what she complained about. It was half that, and the sutures were pulling out. But just going back, and as I mentioned at the beginning, we can change things in polymers. We've got the pullout now where it's twice normal. It works just fine. But this is, to me, at least one of the things we have under our control with nerves. Surface charge. I asked Maruk Datsatan, I said, nerves conduct electricity. Let's see if charge helps. Asked her to put lysine into the polymer backbone. She put a lysine, a +1 charge, every certain number of molecules along the backbone. And I mean, same conditions as the same experimental conditions, unmodified surface on the left and many neurites on the right. They seem to really like, the nerve cells seem to like the charged surface. And when we put them in co-culture with Schwann cells, you'll see some of those axons that grew in culture are thick and thin. The Schwann cells actually myelinated them in culture. Really was pretty nice. So then I thought, okay, if its charged surface works, how about conducting? Nerves conduct electricity. I asked Brett Runge, a PhD in our lab, to see if you can make a nerve tube that conducts electricity. And I said maybe an IPN would work, an interpenetrating polymer network. So what he found, we looked at a number of conducting polymers. He chose polyperol, which, as those of you who've worked with it know, it's black. Everything is black when you make something with polyperol. But Brett found that if we made the tube the way we always made it, made a porous tube, that one of the initiators, chemical initiators for perol polymerization, would wet the internal surfaces of the pores. So, usually when things work, somebody has a great idea like Brett did. It seems really simple. We make the nerve tube the way we always made it. He dips it in the initiator for a while. It diffuses in and covers the pores. Then he dips it in a monomer. When the monomer diffuses in, it meets the initiator in the pores, and it makes a semi-interpenetrating polymer network, meaning the polycaprolactone part is continuous phase, and the polyperol is a discontinuous phase within the pores. We looked at some different types of conducting polymers and chose perol. As you see, the nerve tube is black, but we could make them conducting. And I'll say we're redoing those rat experiments with the conducting polymer now. Remember I said sural nerve is the gold standard. So when we do these, the control group are sciatic sural nerve. The best compound muscle action potential we can get with a sural nerve is maybe 50–60% of normal. It never is as good as normal, but that's the best we can do right now. Up till now, the best polymer that we did was perhaps 1/4 to 1/3 of what we got with sural nerve. We did these rats with this conducting polymer for 12 weeks, and it's the same as the sural nerve. So the first thing I told Juan is, I don't believe it, do it again. So she's doing it again now. So I'll believe it a little better if this next group of rats matches the sural nerve, and then we'll decide where to go. We'll decide where to go with it. Mechanical properties. I told you the mechanical strength the sutures were pulling out, that didn't work. Since we do it in a sciatic nerve, it goes over the hip, it's got to bend. So when we first made these things, we bent them, and they bent like a straw. You'd bend, 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 and then it would flatten at the tip. We thought, just like the PLGA, that when it degraded, the channels went away and got flat, that flat tip like a straw wasn't going to be conducive to axons growing through. So again, we changed the composition a little bit, changed molecular weights a little bit, and got both the pull-out strength to be okay. And in a three-point bending, that looks like it's a little more 90 degrees in the upper right. It may be 100 degrees. It maintains a circular cross-section past 90 degrees, which we think is okay for a first go. Outcomes, we do tracing, we do morphometry, and we do electrophysiology and gait analysis. This is, we put the rats to sleep, do CMAPs. We have we had the gait analysis guy, Ken Kaufman from our gait analysis lab, said, can you make a rat gait analysis? And he did. We made a rat runway, et cetera. And I always joke, I'm sorry I can't remember the student's name who figured it out, but the rats wouldn't walk. And the student made a little house at one end and put some food in it. And we put the rat in at the other end, and sooner or later it wanders across and finds the house with the food. And if you're ready to go, as soon as it does that, you take him out, you put him at the other end, and he walks right back to the food. You get a nice reproducible walk gait analysis each time. And just like humans, we get a standard gait analysis report. Now, I'll tell you, time is out. I should probably not go through spinal cord. If that's okay, I can answer questions later. And let me just go to the end here and get to the... So polymer scaffolds are coming in a firm. We've got both IRB approval and FDA approval for this. We're going to put them in people soon. Rob Spinner had the idea, so I wanted to end with saying these things, because when we get something and we think it works, and then we put it in a human being, it's a different ballgame. Bad things can happen regardless of how good it works in a lab. And so there's got to be clinical equipoise. You got to tell the person what are the risks and benefits, and you got to believe yourself that there's something in it for them. What Rob Spinner told me is we do about 400 sural nerve biopsies a year at Mayo. This is one of our neurologists, Peter Dick, has a test that he does in his lab that is apparently unique to him to help analyze people who have a difficult to diagnose neuropathy or myopathy. It requires them giving up 6 centimeters of their sural nerve. And so they're at a point in their care where they're willing to, it's a sensory only nerve on the posterolateral aspect of the leg that gives you sensation on the lateral side of your distal leg and the lateral side of your ankle and foot. They're willing to give up that sensation to maybe get a diagnosis. Right now, the clinical practice is to leave that 6 centimeter gap and they get a numb spot. We're going to offer them to repair that numb spot. Rob said it'll take him maybe another 10, 15 minutes to sew the 6 centimeter nerve graft in. And so from a clinical equipoise position, if it works, there's something in it for them. They'll get some sensation back, not a pretty wide numb spot. If it doesn't work and nothing bad happens, it's going to degrade and go away. No harm, no foul. They've had 10, 15 minutes extra surgery. If it doesn't work and something bad happens, an infection or some reaction to the material, it's going to cost them another operation, but it's an immediately subcutaneous nerve. They'll have to have their wound opened up and have it taken out, so it will cost them another surgery. We felt that this would be okay, at least I did. I would be okay for mom, dad, sister, brother, son, daughter, if they were in this situation. So we're gonna try this and see what happens. So a firm, we can talk about a firm if anybody is interested afterwards. I think I'm just going to stop there. Thanks for listening very much. I'll be happy to answer questions.
We have a small gift.
That's very kind of you. Thank you.
Sure. And time for some questions.
Arnie.
So Mike, how do you go about doing, in a design sense, real composite implants? Because you started with that as the unmet clinical need, and how do you do composites? Because some of us are trying to put pieces and parts together, and is there a materials logic that we have to follow?
So by composites, do you mean different polymers in a polymer, or metals, ceramics? polymers in any mix and match?
All of the above, but I want to go back to how do you get nerve, muscle, bone, all.
Got it. Thank you. Thank you. I was going to go into that if I got to go through the affirm. That's going to be difficult, and so I'll just say my bias. What my bias is that the focus for composite tissue ought to be composite tissue allotransplantation. The thing that is the biggest obstacle right now to that is the immunosuppression. So I think if you got smart immunologists in a room, please be working on that. Affirm 2 is going to specifically have a vascularized composite allotransplantation arm that was not present in Affirm 1. I told you we just had this board that I chair for the military to look at the investment strategy for orthopedics. We have on that board, and I think we should take heed of this, I think, and do this at NIH and other boards. We have users as voting member of the board, i.e. amputees from these wars that we've been in for the past 10 years. And we asked them about, I'll give answers that 2 of them gave, and it doesn't completely address your question, but I think it's along the path of us trying to understand how to do it. We were debating whether to make an investment in vascularized composite tissue allotransplantation, and as the physicians and scientists were in the conversation, I asked that we pause for a moment and let's ask the people who really know, these 3 wounded warriors here who are missing limbs. One of them had an upper extremity amputation, he had a hook on. And he said, well, look what I do. He said, would I rather have a hand here than a hook? Yes. But he picked the pen up and put it in his pocket. He took a coin out and put it down. He picked the coin up, put it in his pocket. Then he grabbed his coffee cup and picked it up. He said, I can do most things. He said, I don't consider myself disabled. I'd rather have a hand, yes, but he also has gotten, this particular guy's gotten a PhD since he's been injured 8 years ago. He says, I know about immunosuppression. I'm a young guy. He said, bad things are going to happen to me and I will not accept immunosuppression. You figure out immunosuppression and I'm signing up tomorrow for it. The second guy is an ad elbow amputation got blown up in the war. And the point he made was, when I got injured, if you told me you could put an arm back on me within about the first 6 or 8 months after my injury, I would have said, put it on. He said, but it's been 6 years now. He says, I also don't consider myself disabled. I do everything I want to do. He said, and I've learned about immunosuppression. He said, not a chance. So, I mean, although we want to say that there's no difference between vascularized composite allotransplantation and heart, lungs, kidney, liver, well, maybe there is, because in those instances, if that organ is failing, you're going to die if you don't get the transplant, and if you've got to be immunosuppressed, you accept that. In this situation, you're not going to die with your amputation, and at the same time, you may or may not consider yourself functionally limited, is what we've learned from these guys. They don't want it because they feel that they do okay. But they all said that they would take it if it wasn't for immunosuppression. So I know here in town, your colleague Maria Shimanoff over at the clinic is working on induced chimerism. That seems to be working in her rats for face transplant. So I don't know. I think, much as I think that the nerve growth rate is the limiting factor in nerve regeneration, I think that the immunosuppression is going to be the limiting factor in composites. Now, how do we go about making a composite tissue out of polymers? I don't know. I mean, I don't know. That's why I showed that slide at the beginning. How are you going to go about making something that has tendons and nerves and muscles and bone and vessels and cartilage all work together? I don't think we're close to that at all. I don't. If you have some suggestions, I'm listening. David?
I want to give you a chance to talk about different 3D printing strategies. Where do you think we're headed in terms of getting things into the clinic? What do you think is going to work best?
Well, thank you. And as you know, some people are using the strategies that I mentioned for polymers. Some are using for cells. I know that in the Affirm, Linda Griffiths, our colleague in the bone program at MIT, she's printing cells. Now, I have not printed cells, so if anybody knows how to do that, please let me know. But she's got some sort of a printing machine that, instead of delivering polymer that then polymerizes, delivers cells that somehow stay together and make a three-dimensional structure. And maybe, maybe Dr. Kaplan's question could be answered by maybe there's an answer to composite, maybe a three-dimensional printing apparatus that prints bone cells and vascular cells, et cetera, and has them self-assemble would be a way. I of course, didn't get a chance to include everything we're doing. Brett Runge is now looking at supramolecular self-assembly as a next step in our nerve program, in that in trying to get a free exchange of nutrients and wastes for the growing axons inside the nerve tube, while at the same time trying to keep cells like macrophages that want to chew up this foreign body, the nerve tube, away from the growing axons. He's found out that by making a composite polymer, which to a certain extent phase separates, which is how this supramolecular assembly happens, we can make that nerve tube that I showed with nano-sized pores perpendicular to the cross section, so that we make holes of sizes that we can decide on to try to allow oxygen, glucose in, try to allow wastes out, and keep the big cells that would eat things up away. So I guess I'll answer that by saying I do think three-dimensional printing, probably not stereolithography, probably not fused depositional modeling, but these three-dimensional printers like we use for that orange and green scaffold that I showed might be a way if cells can be printed. Maybe that will be a way to get to what you were asking.
We didn't get a chance to see the slides on the spinal cord. Perhaps you could tell us a summary of what your work is in that area.
Good, thank you. The model selection is difficult in trying to get from the clinical need to what we do. The model, I will say now, in 25 years of taking spine trauma call, I've seen 2 transected cords. I've seen a lot of cords that got bumped and don't work, but I've seen 2 that were actually cut in half by the extent of the injury. So if we use we have the Wise Young NYU compression device to make the injury. We can drop a precise weight, a precise distance, and know the force. But if something works, and as I sit at meetings and listen to people show what they do, someone will always raise their hand and say, you can't tell that the resumption of motor activity was from your treatment. Maybe it just happened if you've left things in continuity. So then you come up from the compression device to some partial sections. Some people use a dorsal hemisection, some use a lateral hemisection. Same argument comes up. Oh, maybe there were some axons that got left, and they're the only really way to convince people that your treatment made the axons grow is if you make a transection. But that's not clinically, that's something we don't see clinically. So we use both. We use a RAT T10 transection model. We take 7 millimeters out of the rat cord. So if an axon grows, there's no question where that axon came from. And one of the slides that I quick went through was that slide with the green marked, green dyed axons. Where we're at right now is trying to figure out the reason for the following observation. If we make a transection and put a scaffold in, and we make a scaffold out of polymer, we've made up to 17 or 18 channels, and the rat spinal cord is about 2 to 3 millimeters in diameter. We've made scaffolds with up to 17 or 18 channels in those 2 to 3 millimeters to guide the different corticospinal tract, the dorsal columns, it's a spinal thalamic tract, et cetera. And so that when an axon comes out of the native cord, enters the scaffold, it's likely to go through without moving. It's going to take a straight line. We've got axons to grow out of the rostral cord completely across the scaffold. So it goes across the gap between the rostral cord and the scaffold. And then at the distal gap, it gets across, but we've not gotten any more than about 1 to 2 millimeters. They become disorganized there, and they move in different directions. Having said that, we might say then, well, gee, there's something wrong with that distal gap. But at the same time, sensory axons cross that gap from distal to proximal, go across the scaffold all the way to the proximal junction, get across it for a millimeter or 2, and then become disorganized and don't go any further. So we're trying to think about the guidance after it crosses the scaffold and how to address that. So what we've been doing to try to address that is to try to make a gradient of signals, and we use a variety of things. We're using NTF, NGF, BDNF, and we're trying to do delivery into the CSF. We're trying to do delivery of the molecules into the cord, and putting them at the dorsal entry zone. We'd try to put a microneedle into the cord and put them in there and let them diffuse through the cord. We're putting them in particles. We're doing a number of things. An interesting thing that we've found is we try to use, of all the strategies of the neuroprotection, the axonal guidance, we found what chondroitinase ABC seems to be interesting. And it seems that the axons seem to go a little further away from the scaffold in both directions if we've pre-treated with chondroitinase ABC delivery. And I wonder if it's not similar to like it is in cartilage. The cartilage work that we do in our lab, we use Gordana-Winjak's model of the kind of the lifesaver by cutting the middle out. And if we put something in to digest the glycosaminoglycans and do it in time-dependent contact fashion so they get digested farther and farther out, the cartilage seems to integrate farther and farther out. So there's something that I believe is, I mean, it's written, but I think all of us as scientists don't necessarily believe what's written. But this one I believe. I believe that something about getting rid of the glycosaminoglycans makes a more receptive environment for growth, whether it's cartilage or axons. So I don't know if that answered it, but that's what we're doing right now.
Well, mine's actually pretty short. I've been looking at this slide. What are you trying to communicate to me with this slide?
Trying to communicate here is, thank you. This is for the orthopedists in the crowd. You know, we classify things, whether they're fractures or tumors, et cetera. You know, a little bad, some more bad, real bad. 1, 2, 3. 3 is bad. 3 is real bad. So from a fracture perspective, these things that we're doing for the military in this Armed Forces Institute of Regenerative Medicine are aimed at combat injuries. Having said that, we are hoping, of course, that if anything good comes from it, it will be applicable to the civilian population. But if you look at civilian trauma and military trauma, in military trauma, real bad is about 2/3 of the injuries that happen. In civilian trauma, real bad is about 1/5 of the things that happen. And so whether the treatments we come up with, hopefully, for real bad things will be applicable over a wide range of civilian injuries, we don't know. But those civilians who get injured to the extent that the military trauma exists in our car crashes, et cetera, don't constitute a great percent of civilian trauma, is what I'm trying to get over there.
One last quick question.
Yeah, I was just wondering if you could provide a little bit of insight on, you know, obviously all of these technologies are kind of like platforms that you can use for, you know, different types of nerves, different types of bones, different types of, you know, uses. But I'm wondering, you know, how you, both from the research and the industry side, how you think of the application, what that clinical need is, and, you know, why go after this type of, you know, implant versus another?
Well, I'll address the clinical need. I think the clinical need is paramount. And the example I give is one of the grants that we looked at a number of years ago at the Musculoskeletal Tissue Engineering Study section at the NIH. I was chair of that for about 5 years. We had a grant that was among the best grants I've ever seen written. These two mechanical engineering professors were at a non-research intensive university. Now granted, they should have read the literature and known what I'm about to say, but they didn't. They said that a great amount of the failure in total hip arthroplasty is that the cement fractures and the hip stem becomes loose. They said that they provided a great theoretical study to look at crack initiation, crack propagation, and said that once they had a good handle on this, you know, they would find ways to address this and everything would be great. Well, at that time, the transition was already going on from mostly cemented stems to mostly non-cemented stems. And hardly any of the primaries that our hip and knee surgeons do at Mayo now are cemented. They're all non-cemented, distal fixation of non-cemented stems. And things such as chilling the monomer, centrifugation, pressurization of the canal, et cetera, these things had all been worked out clinically, so it was a non-clinical problem. And I thought, what a wonderfully written grant. If they just talked to somebody ahead of time and somehow taken these great ideas that they had from a mechanical perspective and understood whether it was a clinical problem or not, maybe they could have adjusted what they did. So I don't think that really addressed what you're getting at. But what I'm saying is, it's imperative. This is a team effort. It's imperative that the scientists, the engineers, and the clinicians talk to each other. And among the scientists, it's becoming so multidisciplinary that nobody from a single background can tackle these things. So part of the challenge is understanding who the members of the team need to be. And in our lab, a lot of our lab meetings, we have a weekly lab meeting on Thursdays. A lot of it is someone will say, what does that mean? Because it may be the molecular biologist presenting or the polymer chemist or the biomedical engineer, and they're gradually learning each other's language by talking to each other. And I think that's what I'm going to say. You got to be always talking to the clinicians to see the thing that you're trying to make actually is addressing a problem, whatever that thing is. And then be certain that you have the scientists from the different disciplines that are necessary to address that problem. I'll give one final example on why the team is necessary that also is from the NIH. We had a grant that looked great. It had some kind of transition metal chemistry that, it's not something I understood. I've worked in industry as a polymer chemist. I think I understand chemistry pretty well. I'd never understood it, and it was in such detail that I thought, okay, he's probably got it right. And we were ready to let it go. But one of the guys, the SRA, from the Scientific Research Administrator from the NIH, had taken it to get an ad hoc member of the study section who did that kind of chemistry. That's what this guy did. And when we went around the table and it came to him, he said, I don't understand anything you folks are talking about anything but the chemistry. But from a blank transition metal chemistry perspective, the chance that this chemistry will work as described here is 0. So, you got to have somebody on the team that understands every aspect of what you're doing. So the challenge is to build a team. Again, I don't know if that answered your question, but if it didn't, let's talk afterwards.
All right. Thanks again.
Okay. Okay, thanks very much, everybody.